Again?
Yep.
Okay, I just had to check it off to say that was okay. So very glad to have Tiago Colicchio, assistant professor of medicine, and also one of the founding faculty in the Informatics Institute. He comes to us originally from Brazil. He got his initial education at University of Sao Paulo. He got an MBA there. And then he was in Grenoble, France, where he got a Master of Science in Information Sciences, then on to Utah to the Biomedical Informatics Department there, which is the first biomedical informatics department, maybe in the world. And he got his Ph.D. there in 2017 and came to us, I guess it was late 2017, early 2018. His Ph.D. work was on studying clinical information systems, because before he went to got his MBA, he was working in the IT industry on electronic health record systems, and I guess on Cerner, right, Tiago?
It was a local software in Brazil.
Yeah. Oh, it wasn't. Oh no, Cerner. So Cerner was in
Cerner was in the PhD, yeah.
Right, and so he actually turned electronic health record implementation and installation into a living laboratory to study how these things get installed, where the hangups are, and so on, and has been doing some of that continuing work on that after he came to UAB, but now has been working on looking at how to represent clinical decision making in electronic health records, and working with me with Harushi Dasaniaki, one of our postdoc fellows, Wayne Liang, and now John Osborne. So we're all trying to figure this out, but Tiago's been leading the way on implementing the knowledge representation for that. So I'll let him tell us about his work. So go ahead, Tiago. Thank you.
All right, thank you. I've been having some sinus issues this week. I hope my voice won't fail me here. So I'll be presenting on a series of studies that we have been publishing over the last couple of years with the goal of improving electronic health records. So I'm going to go over some background on the topic, the problems we are facing today, some literature review that we did to see what we could have available to help us. I'm going to talk about the development of an ontology tool that is helping us on our way to fixing the EHR, and a use case where we're implementing this ontology, and briefly over some next steps. So everybody, I believe, heard of the Meaningful Use program, a federal program that provided financial incentives to so that we could adopt EHRs nationally. Meaningful Use was based on many positive studies, so studies showing improvements to quality, safety, and efficiency due to the adoption and use of electronic health records. And it was very successful in promoting adoption of EHR. We went from 15% of hospitals using EHRs for clinical purposes in 2009, all the way to virtually 100% in 2015. So, but there were some problems that came along with it, some unintended consequences. The first one being a hype around health IT. Everybody expected that by adopting EHRs, we would solve the major problems that we face in the US health system. There were a lot of reports saying that, estimating that we could save up to $80 billion annually with EHRs. We could eliminate a lot of unnecessary testing and use of resources. But it turns out that we implemented Meaningful Use between 2011 and 2015. You can see that from the two vertical bars on this graph. And the cost of US healthcare continued to increase during the Meaningful Use implementation and after that. And it's still nearly double the average of the other developed countries. And we still lag behind in some important quality metrics when compared to other developed countries. So what happened is these positive outcomes, in most cases, they were putative outcomes on a general level, because most of these outcomes came from pioneers in the field. Folks like Regent Institute, Columbia University, Vanderbilt, Intermountain Healthcare, Partners Healthcare, Brigham and Women's Hospital, those places in Boston, they built systems locally. They were highly customized to fulfill their needs. And so they were very successful. They had very good outcomes. They improved quality. They prevented medication errors and stuff like that. But these were not the systems that were adopted nationally. The systems that were adopted nationally were the commercial systems for which we lacked robust evidence that these improvements would be generalizable across the country. And so a rhetorical question that we can ask is, the $20 billion invested to adopt EHRs, was it all worth it? From an adoption standpoint, of course it was, but as far as quality and safety and efficiency, this is highly debatable today. We're still working with some of the problems left over. Other things that result from this is there is a saturation of health information technology market. We have an oligopoly in the sector now, because we have basically 3 vendors taking 2/3 of the market share for hospitals, and a little higher variety for clinics, but still a small number. And most importantly, the innovators in the field, they are not investing in informatics anymore. Most of them dissolved their informatics department, or they are just keeping it for minimum operation. And then we have the problem of fixing the EHR with fewer innovators to do the job. Other problems that came along with it, there were a lot of medical legal requirements that came along with meaningful use. Affordable Care Act started to demand a lot of performance reporting, and that required physicians to enter a lot of billing data in the middle of the clinically relevant data. So there's a lot of structured data that they have to enter now, and the notes are significantly longer because they contain a lot of information for billing purposes. They are intended to justify the payment and offer treatment. And so we have the documentation burden that's associated with these physician burnout that we are hearing a lot about it today. And coupled with this, there is what we call data obfuscation. So to compensate for the documentation burden, clinicians copy data from previous notes, making them longer and redundant. And there's a lot of problems with clinical decision support systems that fire overzealous alerts, a lot more alerts than clinicians are willing to accept. And so there is a lot of relevant data masked, buried behind a plethora of clinically relevant data. And now we have this problem of having to fix the EHR, making the EHRs smarter with the systems already in use. So EHRs do some good stuff. They can help us with clinical data repository, so we can store data electronically now. So it's there are a lot of things that we can derive from the data. At least at the organizational level, they do a good job by providing a master patient index. They help with health systems operations. We can manage the logistics of the patient, the medication process from ordering to administration at bedside. They can provide indicators. And of course, they do a good job with billing, which maintains the business. But they definitely are not doing a good job of facilitating data entry and retrieval. Clinicians are spending a lot of time entering data, and it's very hard to retrieve relevant information for decision-making. EHRs don't do a good job providing context, and that leads to a lack of situational awareness. So it's hard for the physician to tell at a glance what's going on with the patient, because to retrieve relevant data, they have to navigate between so many tabs and screens and functionality. There's a lot of searching, and sometimes they ended up asking questions for things that they could find in the record. It's just not easily available. And EHRs are not improving efficiency because physicians are spending a lot more time with documentation than they were before. And some studies are showing that physicians can spend twice as double the time of a visit, a clinical time for a visit, with EHR documentation. So this is not good. There are many suggestions to improve this. Some folks talk about the implementation of Smart on Fire framework, where the commercial EHRs, they would become a platform for external apps. So they would do the basic functionality, but they would function pretty much like the iOS or the Android in your phone. And you could build local applications and connect them seamlessly with the use of standards like HL7 Fire. Others talk about increasing interoperability, bringing data from external organizations so that you can have a bigger picture of what's going on with the patient. Others talk about artificial intelligence. We know that these solutions, they all will play a role in fixing the EHR, but in isolation and working with the EHR as is, they may not solve the problem, because we believe that EHRs will still miss relevant contextual information that's usually known by the clinician, but that the EHR either doesn't have it documented or it is documented there, but as narrative language, as natural language, free text that clinicians put the decisions that they make, their reasoning, their interpretations in the clinical notes, but this is natural language and the EHR cannot process this. This is not readily computable. So you can have questions like, why is this patient on this medication? The clinician knows that. He has a reasoning for ordering the medication. Some other treatment's not working, or the other treatment that would be the best one is not available, or the patient has some contraindication to that. Clinician knows that, but the HR doesn't know this information. And so he cannot help the clinician by retrieving relevant data to inform this decision to the HR. Why an intervention was discontinued? Again, the clinician knows that, but the HR may not necessarily process this information because if it's entered at all, it's as free text. And a question that clinicians are asking all the time, why is this alert being fired? Many times the clinician knows something about the context of the patient that the HR doesn't know. And so the CDS logic, the clinical decision support logic, does not take that into consideration and fire unnecessary alerts that could have being stopped if the CDS logic had more contextual data to process this. So what other organizations and other sectors of the economy do to fix these kind of things? So take an example of Google. If you search a tiny country called Timor-Leste or East Timor on Google, Google gives you a knowledge card, something that looks like this. It gives you readily available a bunch of relevant information about this tiny country. You can know a lot of things just by typing it. It gives you the flag, the map. It tells you it's a country. It gives some explanation of what it is, capital, population, even tells you how far away you are if you want to travel there. Of course, Google is not searching this on the web as you type it. They have this readily available to show you when you need to see it. They do that by using something called a knowledge base coupled with an ontology. Ontology is a concept from philosophy, is a branch of philosophy that's a search for knowledge. And we adapt this to computer science to use ontology as tools that can help us derive knowledge from raw data. Ontologies can give you classifications for data elements into specific concepts so that you can have an identifier for them in standard terminology. So they can be identified without ambiguity. And they can also provide you relationships so that you can link classified concepts together in a way that you can derive knowledge from raw data. So what Google does here is basically use formalism with triples or tuples, comprised by a subject, a predicate, and an object. So they can put in their database, this knowledge base. Timor-Leste is a country. Timor-Leste has capital Dili. Timor-Leste has population XYZ, and so forth. So we believe that a solution similar to this one that Google uses could be implemented in with EHR data so that we can derive a lot of the reasoning elements and a lot of the context surrounding patient's care that is not readily available for the EHR to process. It would work like something like this. So take this sentence. This is a real sentence from a real clinical note. It says, patient is not felt to be candidate for advanced therapies due to lack of social support. So if we have an ontology to tag and classify concepts that we can find here in this sentence, we could do something like this. We could infer that there is an entity here called patient, and there is an intervention, advanced therapies. We could use this ontology to find the equivalent terminology for these concepts, an ID for advanced therapies, let's say in LOINC or SNOMED CT. And then we could have formal relationships to link these concepts together in a way that we can infer what the connection between them mean. Patient has a contraindication for advanced therapies. Why? Because there is a reason. The patient feels like there's lack of social support. So we can formalize the connection between these concepts. And let's say we have a tool called the patient-specific knowledge base, a knowledge base that is separate from the EHR database, that will have such tuples as extracted from data that we already find in electronic health records. And it's specific to the patient because each patient will have a sort of semantic network of multiple tuples connecting the relevant concepts that describe what's going on with the patient in a meaningful way and turning these concepts computable with unique identifiers, both for the concepts and for the relationships. So we could store these tuples in this knowledge base. And then you have the EHR database separate that could be used to populate this knowledge base with the tuples codified and all the identifiers applied to them. And let's say you have a functionality like a patient summary. We can extract data from the EHR. We already have this today. You can show on patient summaries a collection of the latest medications, the latest lab tests, the problems documented for the patient, a list of notes and visits, the encounters, hospitalizations, all that comes from the EHR. But you could add to this patient summary relevant contextual information, for instance, that the patient has preferences for a given treatment or contraindication for a given treatment, and there is a reason for that. So let's say you have a clinical decision support that will fire an alert to a primary care provider saying that this patient of this sentence here is candidate for advanced therapies according to a given criteria in the database. But then from the knowledge base, we know that the patient has actually a contraindication for advanced therapies. It's a preference. Knowing this information, being able to process this through the decision logic, we can block the alert from being fired, because if the patient denies this, he will tell the physician will probably override the alert. So instead of firing an unnecessary alert, we block even before the clinician can see it. So these are some examples of things that we envision could be done if we are able to create such a knowledge base with the use of an ontology. But before we do that, that will require a lot of computational methods, natural language processing to look at the nodes and tag these concepts. Before we do that, we need to know that we have an actual ontology that has all the concepts that are meaningful for this mapping and all the relationships that we can use to meaningfully link these concepts together. The first thing we did on this way was to do a literature review. We did systematic review looking at studies exploring what we call clinical reasoning ontologies, used to empower clinical decision support systems. So by clinical reasoning ontology, we mean ontologies that provide axioms to describe clinical decisions by defining the relationships and the clinical concepts involved in the decision. Here, when we say reasoning, we're not talking about the thought process. It's not the decision-making process itself. It's the result of this decision-making process, the actual decision made by the clinician, the actual interpretation that he or she has about a given finding or the effect of an intervention. So we are looking for ontologies that help us classify concepts that can describe these reasoning elements in a way that you can derive the context surrounding patient care. So we searched several databases from inception to 2019. We looked for studies exploring terminologies related to clinical reasoning in CDS, application and development of clinical decision support systems that use such ontologies, and any computerized method, any computational method that can help us derive semantic relationships that can review the context surrounding patient care. We looked at the ontology purpose, the domain, the knowledge source, and we identified the unique relationships and concepts that they map, that they work with. And we did some quality assessment using the evaluations that were communicated in the studies. And we classified them according to a framework available in the literature. We started with a little more than 7,000 studies, and we did several reviews of title, abstract, and full text, removed the redundant studies and those out of scope. And we came up with a final sample of 40 studies. Those were looked in detail, and we found 38 individual decision support systems that have their own clinical reasoning ontology, what fits our definition of clinical reasoning ontology. We saw that although there is a good variety of ontologies available, they are very specific, very narrow in scope. Most of them look at specific diseases, like there were several ontologies mapping concepts that are relevant for cancer care or for hypertension, for diabetes. Some look at things for specific specialties, like decisions made by radiologists. Others look at the medication process, like identifying adverse drug events, clinical guidelines, and there are a few others even more specific. So from a general standpoint, we couldn't find a single ontology that would serve the purpose of tagging all sorts of relevant concepts that could be found in a clinical note, for example. You cannot be looking only at a single disease or a single specialty. We needed something more robust, but we found them to be very useful for revealing relationships and concepts. We retrieved more than 1,300 unique concepts from them individually and over 600 relationships. But then we did some fine tuning of those. We removed duplicates and we merged those that were similar. And what we found is that we could dramatically decrease the number of unique concepts and unique relationships. We went from more than 1,300 concepts to 164 concepts and over 600 relationships to 137. And we further classified the concepts into what we call medical knowledge concepts and reasoning concepts. The difference being medical knowledge is basically the concepts that are more likely to be structured data, things that you can document for the patient, like a lab test or a problem finding, etc. And reasoning is more related to the decisions and the interpretations of clinicians, a prognosis or the intention of introducing an intervention, how a clinician is interpreting the course of a finding, things like that. So here are some examples of medical knowledge concepts. So for the domain patient, patients can have demographic characteristics, clinical problems, conditions, diagnosis, etc. Treatments they can be an exercise, they can be an indication for something, they can be an intervention of a sort, they can be a goal, they can have a description. So when we talk about medical reasoning concepts, then we are talking about action. So for example, a clinician can have a decision, he can have an assessment, he can be comparing something with something else, he can make a prediction, a diagnosis, prognosis. A treatment can have a decision made by the physician. The treatment can have a purpose according to the physician's interpretation, and so forth. And here are some examples of the relationships we found. A patient can be linked to a diagnosis with the relationship has diagnosis, can be linked to a past finding or intervention with the relationship has history. Symptoms can be assessed by someone, diagnosis can have a severity, a treatment can be part of another treatment or can have a goal, etc. So in general, we found a good variety of ontologies available, but they are very narrow in scope. And we saw that there are multiple ontologies looking at the same domain, at the same type of cancer, for example. And these isolated teams, they're not collaborating. So they keep reinventing the wheel. There are a lot of concepts and relationships that have been used by different teams building ontologies of a similar domain. So there's a lack of collaboration. And our conclusion is we need a more robust ontology than the ones we can find in the literature, and we need them to be standards-based. We need to have these concepts mapped in the ontology, linked to standard terminologies in a way that we can turn these concepts into computable elements that can be processed by the EHR. So this review was published in JAMA back in 2019. And with the input from this review, we went on to develop our own ontology. So this was a multi-method study. We expanded on what we found in the literature, basically expanded the relationships and concepts that we found by manually annotating clinical notes and spoken communications, the communication between the physician and the patient during outpatient visits. So there were several steps here. We started with extracting the relationships from the literature. We iteratively defined an initial sample of relationships we believed would be useful for annotating clinical notes. We used this initial sample to annotate inpatient consult notes. We chose those because we believe there would be a lot of reasoning elements there, a lot of decisions and interpretations, because usually in those cases, a specialist is consulted to provide opinion on the current state of the patient and recommendations about what to do. And so we derived an initial set of concept, relationship concept tuples here. We used those tuples to annotate another type of source, outpatient visit notes, just to contrast with the inpatient ones and see if the tuples would still be useful and if we could identify new ones. Then we have an enhanced set of tuples. We used those to annotate a different data source. We recorded 5 outpatient care, specialty care visits. We transcribed the conversation between the physician and the patient. We transcribed the verbatim, and we used the tuples to annotate the transcript, just like we did with the notes, to see if some more interesting concepts and relationships could be identified, or if the tuples would be applicable to a different data source than clinical notes. And there are two things that are derived from this. So we finished the identification of relevant tuples that could be used for identifying context in patient care. And we were able to compare the tuples that we used to annotate the notes of these 5 visits we recorded. We compared against the tuples used to annotate the transcripts to see if what they communicate verbally is reflected in what they document in their notes. And so at the end, we compared the frequency of use of these tuples across the 3 different data sources: inpatient notes, outpatient notes, and the visit transcripts. Here's how the annotations look like. Very simple. We just used Excel. It was a manual work at this stage. We annotated history of present illness and impression and plan sections only because that's where the narrative data can be found. That's where the reasoning, the decisions are mentioned. The other sections of notes are mostly structured data where you don't have the reasoning elements there. What we did is we took the paragraph or the full text of these sections, we parsed into individual sentences, and 2 authors iteratively looked at the sentences and identified pairs of concepts and classified them into specific classes or domains for that matter. Class is an entity like a patient, or a medication is an intervention. A finding can be a finding/condition, or a diagnosis can be a finding/condition. So we did these classifications. And then we independently, among 3 authors, we annotated these pairs of concepts by indicating what relationship could be used to link them in order to reflect the context represented in the sentences that we had on the left side of this form. And we did this in rounds of 35 sentences each. This was done until we reached satisfactory agreement. And then after that, the annotations were performed by a single author. So at the end, we ended up annotating 626 sentences, about 2/3 from 18 clinical notes and 1/3 from the 5 visits that we recorded. These produced 82 unique concept tuples that use 48 individual relationships and 14 different types of concepts. The agreement was fairly low at the beginning. There were a lot of things that we had to clarify: how to use a relationship, when we're going to call a finding and actually a finding, when it was condition. There were some blurry areas that we clarified. And after those were sorted out, the agreement was fairly consistent. And then the annotations were finalized by a single author. Here's some example of the tuples, and for the 15 most used relationships. The numbers you see on the left, they represent the frequency of use. So from the most common one to the least one. So you have, for instance, finding condition can have an intervention, and then on the other side, you would have the intervention described, and then some example of sentences there. And where those relationships come from is in the source column. A lot of those came from the literature. So the review we did was very useful for that. So we didn't have to invent all these things from scratch. But there are a few very specific ones that were only derived by the annotations that we made. So it was very important to do that. Here's a graph that shows the frequency of use of the tuples according to the data source. So you can see that there were a few tuples that were used only in a specific types of data, like the inpatient notes or the outpatient notes. But most of them were used in 2 or more data sources. And this is a graph that describes the top 15 relationships from a different perspective. You can see in the orange ovals, the classes of concepts, so the types of concepts that we had, and the arrows represent the relationships connecting them. The thickness of the arrow represents the frequency of use. So those that are very thin, they were very rare, and those that are very thick, they're the most common ones. So here I have only 15 relationships in this complicated graph, which means that with a fairly small number of relationships, you can cover the most of the situations that describe context surrounding patient care. So you don't need a great variety. That's what this study showed us. So in summary, there's the usage of the tuples varies a lot, but the 80-20 rule applies. As I said, with a small number of tuples and relationships, you can annotate a variety of different scenarios. One interesting finding is that 26% of the tuples from the notes of those five visits that we recorded could not be used in the transcripts of the visit, which indicates that there are a few things that clinicians do not necessarily verbalize to the patient during the visit, but they put in their notes. This could be either technical things that they don't clarify, they communicate to the patient in more simple terms, or could be things that they were not sure yet at the time of the visit, and they further clarify in the note, or communication of specific technical things that they are going to write in the note so that other clinicians can have access to that. And so that was an interesting finding. And so once we developed this ontology on a conceptual level, it was time then to make an implementation of the ontology. So this annotation study was also published in JAMA back in 2020. And once we had the conceptual study, we got a project funded by the NLM with Jim Semino is the PI, and I'm one of the co-investigators. We have three goals here. We're going to try to implement this patient-specific knowledge base. We're going to try to make that something real and computable. And we're going to test the use of the knowledge base with the patient summary. We were building a semantically oriented patient summary. That is, it's going to show data, structured data that we can retrieve from the EHR as is today, coupled with these reasoning elements and contextual elements that we intend to represent with tuples in our knowledge base. And once we finish that, we're going to do a usability evaluation. So this is ongoing work. What I have to show here is some preliminary data that can give you the gist of where we are headed with this, but it's not finalized. So regarding the creation and populating these knowledge base, there are several things that we are doing. We are mapping the relationships we found in the literature to standard terminologies so that we can turn them into computable elements that can be processed by the EHR. We also chose a standard data model so that we can use as the data schema for our knowledge base so that we don't have to create this from scratch. And the model is the Observational Medical Outcomes Partnership, or OMOP, developed by the folks at Odyssey, which is a collaboration of informatics researchers to create shareable data and shareable data models for informatics research and also clinical research. We are applying a little bit of natural language processing with a lot of manual annotation from all notes that we can possibly annotate from a single patient. We chose a single patient as a proof of concept. Right now, we have a little more than 400 tuples from an entire ER visit, and we're using this to identify the constraints we face in the OMAP data model and see if we need to do any modifications there to accommodate our tuples. And we are in parallel expanding the annotation. We have other 2,000 plus tuples from several other notes. We're trying to cover the entire medical record of this patient to see if we can reflect as much as we can what has been going on with the patient over time. And then we are doing this to populate and create this knowledge base. Here's an example of the hierarchy of the relationships that we have. We put those in Protege, which is an ontology development tool. And here is an example of how we are doing the mappings. So for example, we have a relationship has reason. So an intervention has reason, some justification for that intervention. And we have an equivalent LOINC code that, for instance, is linked to an OMAP code. OMAP has its own terminology that is mapped. So there is a cross mapping here. We can have a local term linked to a standard vocabulary like LOINC that has a link to the OMAP proprietary terminology. So everything that we're going to store in this knowledge base, it can be translated to the EHR in a way that we can link this to the other concepts that we can retrieve from the medical record of these patients. Here's the table where we intend to store our tuples. It's called fact relationship table. It's in the OMAP database. It provides the domain or equivalent to what we call concept class in our tuples. And the fact ID is the actual ID of the event, the actual finding, the actual intervention that fulfills what we call subject in a triple. And then you have the object being the concept two with its domain, and the fact which is the actual ID of this concept. And then they can be linked with a relationship, which will be used with the relationships that we derived from our annotations in the literature. So this is readily available and fits almost perfectly the purpose that we have for this knowledge base. And so it fitted very well. And in terms of the interface that we're going to build, we are looking at the literature to collect design principles, and we had several examples of patient summaries that are available in the literature. And we iteratively designed the mock-up of the interface that we want to build with a collaboration between physicians and informaticians. And we created a REDCap survey to, before start the actual programming, to collect some input from physicians, because this is something that, as far as we know, nobody has been implemented before. The way of connecting things semantically. There were some proposals to do that in the past, but nobody has turned this into reality. And so this is the first attempt. We want to know how clinicians see that. So this is the mock-up of an interface, or how we envision this could look like. So you have the different types of data elements displayed here. So problems would be displayed on a graph. And here you have a timeline representing the problems chronologically. These horizontal bars that you see here, both in the problems graph and the interventions graph, they represent the time frame of the problem or the intervention being active. So if the bar appears here, it means the hypertension is still active during this whole period. And, gout started here on this date, and then it's active on that time. These orange circles represent lab tests, the blue ones represent imaging tests, and these vertical bars represent the encounters. They are repeated across the graphs because it's intended to reflect the chronology. So everything is talking about the same period of time here. I can scroll down to see the remaining graphs on the screen, and the vertical bars will be repeated to show the same chronology. So I can go back up. If I mouse over, so I could mouse over lisinopril, and then the system would reveal to me what these superscript numbers 1 and 4 mean. They mean linkages that we stored in our knowledge base, which indicates that lisinopril treats hypertension. So there is a tuple saying the hypertension has intervention lisinopril. There's another tuple saying that this lisinopril can cause cough, and cough is entered as a problem in the problem list. So I can reveal to the user what these superscript numbers mean. If I mouse over the lab test, it can reveal to me what are the labs with a summary of the results. If I mouse over the vertical bar, it can show to me what this vertical bar is. It's an ER visit, and there is a link to the discharge summary. So I could click in the hyperlink and see the discharge summary without needing to go back and forth between models. So if I mouse over this blue circle here, the system could reveal to me that this is an imaging report. So there is an endoscopy. Again, I can see the link to the report readily available. I could mouse over this test that is outside the graph. If it's outside the graph, it indicates that in some cases, we may not know to infer a priori what's the relationship between this lab test and the problems of the patient. We could create a functionality like a simple drag and drop that the clinician could drag this and drop on top of the problem for which the lab test was ordered. And so we could create a relationship that would be added to the knowledge base. A challenge that we're going to face that we anticipate is that not everything will be mapped before we show this to the physician, and we are going to need some collaboration with data entry, and we cannot add more burden to the documentation because clinicians are already overwhelmed with this. So this is a strategy that we can think of doing this. Once we establish the link, now we have a tuple in the database. We envision that ideally we could have some sort of natural language processing coupled with machine learning, looking at the notes and see if we have a tuple saying that this lab on this day was ordered for monitoring or diagnosing gout. We could look for the mention of these two concepts in clinical notes. And if we find that, we could show a hyperlink here showing this connection. Not only you could show the text, but since we know that these concepts are linked together, there's a connection between them, we could even highlight the text where gout and creatinine appear, showing the decision that or the interpretation the clinician has. All those will be tuples in the knowledge base. So we can use this information and turn this computable. Today, it's raw data, natural language, and it's not used by the EHR. So the goal is to try to make this something useful. Another thing is if I mouse over a problem, the problem could become a hyperlink so that I could have details on demand. If I want to click on hypertension, I could have a detailed view of hypertension. So only things related to hypertension would appear. So this simulation that I just showed here, I recorded a video of this simulation and we added to a long-line survey. We also put in the survey 2 lab visualizations that we created. One that we call a scaled lab visualization. Basically, we grouped the lab results by the scale of ones, tens, and hundreds, and so forth. Just hypothesizing how clinicians would see this. Another one is the normalized view, where we normalize the trend of the result according to the upper and lower levels of each test. So it's not dynamic here, but if I mouse over, I would reveal the values of each one of these data points, and then I have the beginning and the end value in the name of the test, with the obvious limitation of not being able to show too many results with a visualization like that. But just for the purpose of exploring some input, what they think of these visualizations. And so we did a red cap survey. We invited UAB physicians, residents, fellows, and attending physicians. We asked them to rate the video with the simulation of the patient summary that I just showed here, and to rate the 2 lab visualizations. We asked them 3 questions for each one of the 3 items, the patient summary and the 2 lab visualizations. The questions were basically, we provided the sentence and asked them to rate if they agree or disagree. The patient summary will improve my ability to understand what's going on with my patient when I'm performing chart review. So the patient summary is intended to be used before seeing the patient in an outpatient visit. And the other one is when compared to the current EHR I use, the patient summary would be more informative for chart review. And we inverted the 3rd question just to see what they would respond to that. If we ask it if they find it confusing, we really didn't know what to expect from this. And then we decided to ask this for them. We asked the same things for the 2 lab visualizations, just replacing instead of the patient summary, we asked the scaled based visualization, will improve my ability, etc. And at the end, we had 2 open-ended questions for comments. General comments regarding EHR navigation. They could tell us any challenge they have today or suggestions to improve EHR navigation or to improve the patient summary. We left it open. And then we did a thematic analysis of these comments. We had 49 respondents. They were mostly male, specialty care, and an overwhelming majority of attending physicians. We calculated internal consistency with Chromebox Alpha. Consistency was pretty high, which indicates that we had a high reliability, meaning the questions were interpreted in a similar way. There was no great variability on the response, so it was not there was no ambiguity. Here's the ratings for the questions regarding the patient summary. If they find that they will improve their ability to understand what's going on. It was slightly positive, was above neutral, close to green. And when compared to current EHRs, they found it was also slightly positive. And most of them didn't find it to be confusing, which was a relief for us. We didn't know what to expect from that. Regarding the lab visualizations, they were not well accepted. Both lab visualizations had the ratings below neutral, so they slightly disagree that they would be a good resource for them, and they found it to be confusing, both the scale and the normalized one. Here's some summary of the thematic analysis. We had 77 comments overall. There was a good agreement between the 2 raters. We had 6 themes. There were a lot of complaints and suggestions, mostly for improving visualization and data retrieval. There were a lot of problems mentioned by the physicians with the lack of access to data relevant for decision-making process that is readily available. They have to navigate between many tabs. There's a lot of clicks. And to retrieve relevant data, there's a lot of searching, and finding the right note, it's fairly complicated. And some of the comments supported the proposal that we have, like this first suggestion on the data visualization. It would be nice if we could have a trend for a certain laboratory, and then we could show when the medication started. That's exactly what we are showing on our summary. And there were a few comments regarding problems with data quality, meaning that such a summary is only as good as the quality of the data that you have stored, and some comments regarding context, which is also the purpose of what we are doing, to review, to turn the context surrounding patient care computable and understandable by the clinician in a more digestible way. So in conclusion, the integrated summary was slightly positively rated. There were some complaints about the labs. The clinician said that basically what the EHRs provide in terms of lab is sufficient for what they need. So a basic trend of labs is enough. We don't need to do anything fancy. And we decided to further analyze the comments that were for, which is neutral, or below, and look at the comments that the respondents provided for that, to understand why they provided so many positive comments that attested that what we are doing is positive and it's the right direction. But then the ratings did not necessarily reflect that. They were not above 5, which is what we expected, that they would agree, that would improve their ability to understand what's going on. What happens is many respondents, that's a hypothesis that we have, they looked at the summary from the perspective of what they have in their EHR today. They have bad quality data. So if the physicians do not keep the problem list up to date, maybe what we are going to show on the graph may not be good enough. Or if we used a simple use case, so we have a patient with only 6 problems, but that may not be realistic. Sometimes the patients will have 20 plus problems. This is all true. And we believe this may have influenced the way they saw the patient summary, and maybe we didn't clarify this enough. These are all problems that we're going to face, and during the annotations, we are trying to work with that now. But at this conceptual stage, this was not intended to be resolved at this point, so we understand this. Despite of that, we have a lot of positive comments, and we are using those for the development of this patient summary. So the survey was published in the International Journal of Medical Informatics earlier this year, and this is a screenshot of a draft of the patient summary as we start to build it. This is ongoing right now, under development, and so we are creating the graph of the problems and the interventions. We're going to start adding the vertical bars, and we're going to start adding the circles representing labs and tests, and then the superscript numbers and all that. And we're testing multiple ways of filtering and navigating and scrolling and expanding when you have problems that we're not showing count of past problems. They're not appearing here so that they know there's something back in time. So we are testing multiple iterations with the input from the physicians. So next steps, other things that we are considering applying this ontology. A big problem is alert fatigue, this desensitization that clinicians face because they're overwhelmed with overzealous and clinically irrelevant alerts in decision support systems. And a big champion on this is drug allergy alerts. Drug allergy is by far the most overridden alert here at UAB. It's nearly half of all the overrides we have. And it's frequently among the top 2 most fired alerts and most overridden alerts in many organizations. You can easily find overrides above 90%. And what's most significantly is that most of these overrides, they are appropriate, meaning they are really irrelevant alerts. They shouldn't have been fired. There are a lot of problems with keeping the allergy documentation up to date and accurate. There are a lot of side effects. There are minor reactions that are confused with severe allergy reactions. And if they are documented as allergy reactions, there will be an alert fired when, in fact, the patient has taken the medication before and has tolerated. This is very common. And there's a lot of problems with cross-sensitivity. There's allergy documented for morphine, but the patient is receiving fentanyl. because both medications are opioids, the system fires an alert. But the patient has had fentanyl before and has not had any reaction. And so the alert shouldn't be fired. So we're collecting data now to use the ontology that we built to annotate clinical notes and structured data to see if we can create a criteria to identify potentially false positive allergy documentation so that we can change that from allergy to minor side effect, and then use the decision logic of the decision support to avoid firing these alerts because they're probably unnecessary alerts. And we're going to try to do randomized trial to see if this is effective. Other things that could be useful: automatic generation of text that could be used for populating clinical notes. If I can record the conversation between physician and patient, transcribe the verbatim, apply natural language processing, and annotate the transcript like we did in one of our studies, probably could create some standard sentences that could communicate something that the clinician intends to do with the patient so that they don't have to type that in the note. This is something that it turned out to be a little bit more complicated than we expected. We submitted a grant for this. It was analyzed, it was discussed, it was scored, but didn't get funded. There was some criticism on lack of innovation of NLP, which was not actually the goal here, but we believe this is still feasible. We're going to go back to this probably in the future. And probably we can also use this for improving context in data sets for secondary research, for learning health systems, or even for improving identification of patient cohorts for clinical studies. So these are some things that are on the radar. So that's it. Appreciate your attention and happy to answer any questions if we have any.
Yeah, thanks for the excellent presentation. You know, it's amazing how much collaboration is involved because there's so many different pieces, and talk about the electronic medical record and text ontologies. So, so yeah, thanks for that. Please enter your questions in the chat or feel free to unmute yourself. We have a few minutes. If you have any specific questions or comments.
Hi, it's Jim. I don't see any questions in the chat or hear anything, but we have a lot of clinicians on the meeting. I wonder if they have any reaction to these kinds of somewhat revolutionary ideas about how to represent data in electronic health records. Some of you are not shy, I know.
Hey, Jim, this is James Willig. I really like the ideas. I was sort of thinking about the traditional notes section and how it just grows to multiple screens over time, and how sometimes it's challenging to find the right piece of data, and how this would be a very different visual representation of it. So it also reminds me of sometimes you'll see some seasoned clinicians kind of put, we call it a cobogram because Glenn Cobbs is the old ID guy that first taught all of us it. And he just kind of puts kind of like a timeline with a line like you guys were putting in which symptoms showed up on which date. So to me, it felt pretty natural. I think Glenn Cobbs certainly didn't come up with that. I've seen other specialists do it. So I think that there's some resonance to the way that some people visually represent that information. So I think it's doable, and I don't think it'll be super strange for most people. I think people will get it.
This is Jeff Curtis. I think this is great. And Tiago, thanks for your excellent presentation. I mean, I feel like EHRs have under-delivered on the promise to be smart enough or to have extractable data to know why clinicians are doing something. So in my world in rheumatology, like why you quit taking a medicine, why you have to switch or you stop something, like in most medicine subspecialties, including rheumatology, that's gigantic. You're not going to get that out of structured EHR data. So I think that this approach has huge applications for, real world evidence generation, for comparative effectiveness and safety research, but it also has, I think application to maybe somewhat mundane but important things like helping a clinician, develop an automated process, ideally an informatics approach to prior auths, because most of the drugs we use in the autoimmune space are incredibly expensive. You always need a prior auth, and what insurance always wants to know is, what have you been on in the past, when, and why did you stop, and how long were you on it? And the why did you stop part, like that is a manual lookup every time. And so answering some of those, why was this decision made questions, and then codifying that, to me, that's helpful for research and, clinical operations to improve efficiency. So this is great work, and I'm excited to see as this develops.
Sure. Thanks. Yeah, that sounds like a good use case to explore. Yeah, appreciate it. Thank you.
I have a question. I know there's probably a lot of challenges and kind of what would have to happen, or what would we need to do to sort of get this in the front line, and especially the EHR providers are not always amenable to making changes. Would this be like a smart on fire type thing, or how can we get this to the bedside?
Yeah, that's a challenge. It's not only the providers, also the vendors, because it's very hard to interface with the commercial software. Most of the time, we're going to have to use proprietary APIs, and that limits what we can do. We are starting with something that's completely separate from the database level to the interface level. And ideally, we can send data back to the EHR, but this is something we're going to have to do by convincing the clinicians to help us negotiate with the vendor. Hopefully, they can buy in by seeing the value of even making entry easier. This is something we expect in the mid to long term. First, we're trying to convince them to see that by connecting things a priori, we can have a better idea of what's going on with the patient. Once we can do that, if we can convince them to enter some additional data at the expense of some time they will spend now, by saving a lot of time in the future, by, for example, I can help them with data entry in the future if we know something in advance now. These are things that probably can help us have some technology champions that will help us put this at the bedside. We're definitely going to need to convince them first. And that's the challenge we're going to have to face with this usability evaluation that we plan on doing, hopefully in the spring.
There's a related question that having these ontology integrated, such as on an iPad or tablet, that kind of integration probably is similar to the other question, but I don't know if there's anything additional.
Oh, the idea is that this should be a web interface, so you could use this anywhere. That's the goal. Eventually we're gonna create a button inside Impact. We can open this. The browser will open there. It looks like a module within Impact, but it's not actually Impact. It's our software. We're just collecting data from the same patient that you have opened on Impact, but we probably can envision this being used anywhere as a web interface.
All right, well, we're at the top of the hour, so I think we're out of time. But thank you everybody for attending, and for Tiago for the great presentation and for all the questions. And hope everybody joins us for the next Power Talk. Thanks very much. Bye-bye.
Thank you.